Mr. Shaw said that even that's the case, it's never too late to work to restore trust. So most characterizations about race and ethnicity and trust presumes that it's only the dispositional trust that actually matters. They don't think about the situational trust issues. And I'd like to say that that's a problem. So here we have in quotes from the literature, mostly found in the commentary section or the discussion section of paper, a series of ideas about trust in minorities, which I categorize as stereotyping. For example, trust needs to be cultivated in minority patients. Or among African Americans, the reasons for not having advance directives in this case may involve issues such as distrust, or this lack of trust and suspicion is a significant influence on the attitudes of African Americans. Now the problem with this, there are a couple of things. One is that this idea of trust needs to be cultivated in minority patients says nothing about the trustworthiness. I'd much rather, if it were going to be a commentary, that it says trustworthiness of the healthcare system needs to be cultivated to better serve minority patients. But that's not how it's framed. It's framed at pointing to the victims of untrustworthiness, people who have been victimized by that. But the other point is that it creates this stereotype image of minorities as being dispositionally mistrustful. In our research, now there may be some cases where that's true, but most of the times, minority patients desperately want to find someone they can trust. And they enter into the healthcare system hoping that people will be trustworthy in return. So in other words, their ability to think about trust is much more situational. What kind of ways were they treated once they entered the healthcare system, rather than some predisposition they brought in with them. So I want to return to that context that I started with, that the investigators measured lots of variables. If you look at their table from their study and the logistic regression that they did, lots of variables to try to figure out what can account for this persistent disparity in race and the use of genetic counseling and testing. And they measured lots of things about socioeconomic status, cancer risk perception, worry, et cetera, but they did not measure trust. So I go back to asking, was it a fair conclusion if they didn't even measure it? Were they stereotyping and presuming that blacks are going to be, or African Americans are going to be, dispositionally mistrusting of genetic testing? I wanted to look at this further and most recently did a systematic review of empirical studies. That is, I don't want to know about commentaries and people's ideas. I want to know, did you actually measure trust? And if you did, what did you find? So we did a systematic review over a 5-year period of time, looking at articles over a 5-year period of time. We were able to find from our literature search 224 articles, and once we excluded them because some were not empirical, again, we're only wanting to know empirical studies. Did you measure trust? We excluded studies that measured proxies of trust but not trust itself. We excluded non-US studies, and then we finally excluded those who did not measure trust among African Americans. And unfortunately, on that body of literature, there were only 18 studies. Not enough for us to draw a lot of conclusions statistically. In addition, most of them were mixed. That is, there were a combination of focus group, qualitative studies, ethnographic studies, as well as some surveys. But the one, just jumping to the conclusion, is that one thing we found is that the conclusions drawn in the studies from what they measured was really dependent on the kinds of questions they asked. For example, there was one study done in the VA system in looking at cardiac patients, asking situational questions. That is, your particular physician that you went to and the kind of experience you had. So they placed the trust potential in an actual situation. You know, could you trust that? And so they got their answers to that. There was another study, very similar, looked at a similar cohort of patients, that is, cardiac patients, but their questions asked dispositional questions. Do you think hospitals in general or physicians in general discriminate or treat you badly? So that's asking someone to think dispositionally. These two studies found completely opposite findings. The ones that asked situational trust questions found that the African American patients were equal to, and in some cases, more trusting of the whites that they compared to. But the study that asked dispositional questions found that African Americans were more mistrustful. Neither one of those studies will tell you what's going to happen with a particular patient. It's if they'd asked both questions together, we might have a fuller picture. But you really cannot draw conclusions about a population. The literature's not there, the evidence is not there yet for us to say any one group has a tendency to be any one thing. The real take-home message from that is I really think we need to start looking more at the situations. Those are the things that we can make changes. In the last few slides, I want to perhaps review some of the things that you've had in some of the earlier modules. I know you've talked about disparities. I think, and again, as I draw out some of these ideas and models of trust, these are abstract ideas. So they're subject to sort of playing around with. And I think that there's a place where we can think about situational trust and dispositional trust coming together, and that is in the area of healthcare disparities. So let's go back to our simplified schematic for that. Let's say that we have a patient who they know about Tuskegee. They're really worried about the kind of healthcare or treatment that they'll get if they got involved in research, et cetera, et cetera. And so they have a predisposition to say mistrust. And they have an encounter. And in that encounter, they are not able to have equal access to quality care. And so the care they give is compromised in some way. That it's an overtaxed, under-resourced facility that cares for, let's say low-income families or patients. And that because the providers and the clerical staff and the groups that are there are so overworked that they're stressed out and they come across, they're perceived as uncaring. And things fall through the cracks. This is a teaching hospital. The teachers, the providers there, the attendings are more interested in making sure that their residents learn these procedures. So there's a lot of conflict of interest. That kind of disparity in care, in the quality of care, certainly reinforces that predisposition. And so the mistrust is reinforced. So it's not only unchanged, it's reinforced. So the situation is there as well that's feeding into this trust stance. What's happening in those kinds of situations? I'm hoping that you've had exposure to the Institute of Medicine report titled Unequal Treatment that came out and talked about the disparities in race and ethnic-based disparities in healthcare in this country. One of the things that they talked about in this report are the provider mechanisms that could account for these disparities. And again, we meet our friend stereotyping, and these are the attitudes that are held about, or beliefs that are held about particular groups held by providers, and how these get in the way of providing good, trustworthy care to patients. I gave you a scenario of potentially an overworked, under-resourced facility and the stress that these providers are under. One of the things that came out of the Institute of Medicine report is that it's these kinds of stresses that might account for prejudices and stereotypes, that most people don't wake up in the morning and say, I think I'm going to stereotype people today, or I'm going to conscientiously be biased. The problem is that most of these behaviors are unconscious. They're implicit in our attitudes. And I particularly love this quote, even though it's written at a time where gender appropriateness in language was not the talk of the day, so pardon the gender exclusivity, but every man has reminiscences which he would not tell to everyone but only his friends. He has other matters in his mind which he would not reveal even to his friends but only to himself, and that in secret. This is the important part. There are other things which a man is afraid to tell even to himself, and every decent man has a number of such things stored away in his mind. These are the things that we need to be concerned about. That